Welcome to the deep dive, where we take the crucial foundational knowledge for clinical practice and really distill it into memorable, actionable insights.
Mhm.
Today, we are undertaking a deep dive into material that is, it's absolutely non-negotiable for success in medical surgical nursing.
Or really any field of nursing.
Any field, that's right. We're talking about understanding the complex, sort of interlocking concepts of disability and chronic illness.
That's so true. This isn't a niche topic you might encounter, once in a while.
Not at all.
If you work in healthcare, whether it's the ICU, a long-term care facility, a community clinic, the operating room, you will encounter patients living with chronic illness and disability
Every single day.
every day.
Yeah.
And these individuals, they span every age, every ethnicity, and every socioeconomic background. So our mission today is really to move past simple definitions.
Right.
We need to clearly define these concepts, analyze the different models of care that, shape our approach, and establish the essential legal and clinical frameworks we need to provide truly comprehensive, high-quality care.
Okay, let's unpack this right from the start. We have to establish the language we're using because these three terms, chronic disease, chronic illness, and disability, they get used interchangeably all the time in general conversation.
All the time.
But the distinction is absolutely vital for developing an effective nursing plan of care.
It is fundamental. So we start with chronic disease,
Okay.
or you might hear chronic condition or
Oh.
disorder. This is the physiological reality. It is the long-term medical problem itself.
The pathophysiology.
Exactly, the pathophysiology,
Yep.
often referred to as a non-communicable disease. So think diabetes, COPD, heart failure, conditions that require management over a prolonged period.
So if the disease is the physiological reality, the biology, then what is chronic illness? I think this is where a lot of new clinicians can sometimes miss the depth of the experience.
It's the human element. Chronic illness is the experience of living with that disease.
Ah.
It's the person's perception of their condition and their responses, cognitive, physical, social, to living with that chronic disease. The disease is biological. The illness is this constant day-to-day negotiation and adaptation.
It's the subjective feeling.
It is. It's how it feels to live with it.
That distinction changes everything because it forces us to see the patient as a whole person, not just a collection of symptoms.
Exactly.
So now let's define disability within this triad.
Okay, so disability is the consequence of an impairment. It results in a restriction or a total lack of ability to perform functional activities.
So it's about performance.
It's all about performance.
Yeah.
Being limited in activities of daily living ADLs like feeding, bathing, dressing, or instrumental activities, IADLs like communication or mobility. It's the measurable limitation of function that stems from the disease or injury.
Perfect. Understanding that triad disease, the biology,
Right.
illness, the experience, and disability, the functional consequence, that gives us the conceptual foundation we need.
So let's jump into the scope of disability itself. The sheer numbers globally are staggering.
They really put this issue into perspective. The World Health Organization, the WHO, estimates that over 1 billion people worldwide have some type of disability.
It's a billion.
A billion people. That's approximately 15% of the global population. It makes people with disabilities the world's largest minority group.
And the disparity within that group is it's heartbreaking.
It is. Over 80% of that billion live in low and middle income countries.
Wow.
And just think about the implications of that. These are settings where social services, assistive technologies, even basic primary care are already strained.
So it just compounds the challenge.
It compounds everything.
Okay, so shifting to the U.S., the CDC reported that 61 million adults,
1 in 4.
1 in 4 non-institutionalized adults, have a disability that negatively affects major life activities. And that number isn't static, is it? It's increasing. It's
Yeah.
increasing, yeah. And that's primarily because we're just getting better at keeping people alive.
Right.
Advances in trauma care, medicine, critical care.
Right.
They mean people who suffer severe trauma or acute, life-threatening chronic disorders are surviving longer, but often with resulting functional limitations. We are, in effect, creating an increasingly large population of survivors who need lifelong, specialized care.
And when we look at that U.S. data, we see very specific groups with higher prevalence rates.
We do. Disability is higher among American Indians and Alaska Natives. Adults living below the federal poverty line, African Americans, and whites compared to Hispanics and Asians.
And those disparities really highlight the role that social determinants of health play.
Absolutely. In both the acquisition of the disability and, just as importantly, the access to resources needed to manage it.
This prevalence data leads directly into the critical socioeconomic reality, which, as nurses, we absolutely have to confront: the employment gap and the poverty rate that comes from it. These are system failures that directly impact patient health.
This is a major area for nursing advocacy. The data shows this massive gap. Only about 19.1% of working-age individuals with disabilities were employed,
19%.
compared to nearly 66% of those without disabilities.
Wow.
And that lack of employment translates directly into financial precarity, leading to a poverty rate of almost 30% for working-age individuals with disabilities.
30%. That is 3 times the rate of poverty compared to the non-disabled population. So when you, as a nurse, are trying to manage a patient's chronic condition, you have to realize that this financial reality dictates everything:
Everything.
medication adherence, access to transportation, proper nutrition, follow-up care.
Precisely. If we don't understand that their experience is inextricably linked to low income and limited healthcare access, due to a lack of insurance or high copays, then we're planning care in a vacuum. The inability to afford an accessible ramp or necessary equipment becomes a life or death scenario.
Before we move on, let's clearly define how the health system actually categorizes disability. Let's move beyond that general scope.
Okay, we can break the types down systematically. First, we have cognitive disability. This involves limitations in mental functioning that impact daily life.
So things like communication, self-care.
Exactly. Communication, self-care ability, social skills, and the capacity for independent living.
Then there is the broad category of developmental disability.
This is an important umbrella term because it has a specific age marker. The disorders must have their onset before 22 years of age.
Okay.
It's a heterogeneous group, including disorders with physical, cognitive, or combined impairments. So things like cerebral palsy, spina bifida, or Down syndrome.
And related to that is intellectual disability, which is a slightly different definition.
It does. Intellectual disability has an onset before 18 years of age.
Right.
And it's characterized by significant limitations in intellectual functioning like reasoning and problem solving, and also in adaptive behavior, which means those everyday social and practical skills needed for self-care.
Next, we cover sensory disability.
This is an impairment of sight, hearing, smell, touch, or taste, though most frequently in the clinical setting we deal with vision loss and hearing loss.
And nurses need to recognize the secondary risks here.
Oh, absolutely. Things like isolation, decreased cognitive function from lack of stimulation, poor overall physical and psychological health, and a significantly increased risk of falls.
Which leads to injury or hospitalization.
Exactly.
We also must address psychiatric disability.
This refers to a mental illness or impairment that substantially limits major life activities like learning, working, socializing, or communicating. And these are real, tangible limitations that require accommodation and careful, non-judgmental nursing care.
And finally, a category that is probably most common in the med-surg environment: acquired disability.
Yeah. Acquired disability results from an acute event like traumatic brain injury, a TBI, or a spinal cord injury, an SCI, or from non-traumatic acute disorders like a severe stroke or an MI.
It can also come from the progression of a chronic illness.
Right. The progressive nature of a chronic disorder, like vision loss from diabetic retinopathy or the mobility decline from progressive MS.
It's so crucial to acknowledge the difference between visible and invisible disabilities. I think as providers, we often miss the invisible ones, and that can lead to a real breakdown in understanding.
Absolutely. The source material really emphasizes that invisible disabilities, which might involve chronic pain, severe fatigue, or limitations in instrumental activities like managing finances or preparing meals, can be just as profoundly limiting.
As those that are immediately visible, like needing a wheelchair.
Exactly. As nurses, we must always assess function, not just appearance.
Okay, before we transition, we need to hammer home the difference between secondary health conditions and comorbidities. This distinction shapes the entire preventative aspect of nursing care.
It really does. So a secondary health condition is a disorder that results directly or indirectly from the primary disability.
Okay, an example.
Think about a patient with a spinal cord injury or spina bifida developing recurrent UTIs.
Right, from catheterization or a neurogenic bladder.
Exactly. Or pressure injuries from prolonged immobility,
Hmm.
or even depression stemming from the social isolation caused by mobility barriers.
So why is recognizing that causal link so important?
Because so many of these secondary conditions are entirely predictable and preventable with appropriate proactive nursing assessment and intervention,
So if we see one, it often signals a failure in the care plan.
or an environmental barrier that hasn't been removed, yes.
And comorbidities, by contrast.
Comorbidities are conditions that occur independently of the disability. They are separate health conditions like high blood pressure or cancer that could happen to anyone, regardless of their disability status.
So a nurse manages both, but understanding where it comes from, is it a consequence of the disability or a separate issue? That's key.
It's key to planning holistic, effective care.
That distinction, identifying what is preventable versus what is independent, brings us perfectly to the core issue of how we view and approach disability. Let's jump into segment 2 and analyze the models of disability, because the lens we use really dictates the quality of care we deliver.
This is critical. How society, and specifically the healthcare system, defines disability determines whether we empower or disempower our patients.
Okay.
So if a nurse operates primarily under the traditional medical model, they view disability as a problem residing solely within the person.
So the patient is broken and the professional is there to fix them.
Exactly. Disability is seen as directly caused by the health condition, requiring professional intervention, cure, remediation, or adjustment.
What's the problem with that model? It sounds medical.
The problem is profound. It promotes passivity and dependency in the patient. It centers all the power in the hands of the healthcare provider, who's positioned as the ultimate authority.
And the rehabilitation model seems to stem directly from that same viewpoint.
It does. It views disability as a deficiency that requires a specialist to fix, focusing heavily on maximizing function, often back to some previous state.
The negative consequence there is that patients might be seen as failing.
Exactly. If they don't overcome the deficiency or they don't meet the prescribed rehab goals, it can be highly damaging to their self-esteem and sense of agency.
This is where we see a radical shift with the social model, sometimes called the barriers model.
The social model flips the script entirely. It argues that disability is socially constructed.
Meaning the limitation isn't in the person's body.
Right. It's caused by the physical and social barriers that society erects. If a person who uses a wheelchair can't get into a clinic, the disability isn't the inability to walk, the disability is the lack of a ramp.
The focus shifts from fixing the person to removing the barrier.
It does. It immediately dictates nursing advocacy. If the problem is external, the nurse's job is to change the environment.
So to try and integrate these views, the biopsychosocial model emerged.
Right, attempting to fuse biology, the individual's experience, and the social context. It's broader, but critics argue that even this model often still foregrounds the medical diagnosis.
So the disabling condition remains the defining feature.
It can, yeah, rather than the person's functional reality.
We also have the WHO's functional model, the ICF.
Right, the International Classification of Functioning, Disability, and Health. It provides a truly standardized framework. It focuses on how health and environmental factors interact to create impairments and activity limitations. It's crucial because it frames disability as a component of health that interacts with the environment, not just a tragic outcome of disease.
But the source material highlights the interface model as the most empowering framework for nursing practice.
And fittingly, it was developed by a nurse.
Oh,
The interface model is where we should anchor our philosophy. It views disability at the interaction point, the interface between the medical diagnosis and the environmental barriers.
what makes it so transformative?
Its core principle, the person with the disability defines the problems and directs the solutions. The nurse's role isn't to prescribe solutions, but to facilitate the patient's self-directed goals. It maximizes empowerment.
Critically analyzing the influence of these models forces us, as nurses, to move beyond just treating the diagnosis. How do we ensure that practical nursing management reflects this person-first philosophy?
We have to constantly monitor our care plans. We must shift our focus from the strict pathophysiology to the impact of the disability on their ability to perform self-care, to adhere to health screening schedules, to maintain overall well-being.
The goal must be to ensure that modifications are made so that people with disabilities receive health care that is equal to that of people without disabilities.
That equality is the standard.
And the simplest, most fundamental nursing action that reinforces this shift in perspective is the mandatory use of people-first language.
This is just non-negotiable professional practice.
Yeah.
We must never allow our language to equate a person with their illness or condition.
So the patient with a disability, not the disabled patient.
Exactly. The person who is a wheelchair user, not the wheelchair-bound patient. This seemingly small shift in vocabulary has enormous power. It signals immediately that the patient's identity and personhood are the priority, not their disorder.
That shift in mindset is powerful, but it doesn't mean much without the legal teeth to enforce it. Let's move into the crucial legal framework in Segment 3, detailing the federal legislation that mandates access and quality care.
Okay, so the legal mandate really starts with the Rehabilitation Act of 1973.
73, okay.
This law protects against discrimination in programs or organizations that receive federal financial assistance, since most hospitals and health systems rely on federal funds.
Which is pretty much all of them.
Almost all of them. This law forbids them from denying people with disabilities equal access to their benefits and services. It establishes that initial precedent for access.
But the legislation that truly changed the landscape for healthcare access is the Americans with Disabilities Act of 1990, the ADA.
The ADA is foundational. It mandates comprehensive access to jobs and the community, prohibiting discrimination. And in a healthcare context, it requires reasonable accommodations.
And this goes far beyond just providing a ramp.
Oh, far beyond. We are talking about accessible facilities, wide doors, grab bars, elevated toilet seats, and crucially accessible medical equipment like adjustable examination tables.
And accommodation for communication, which is so often overlooked.
Absolutely. The ADA requires alternative communication methods, like certified sign language interpreters for patients who are deaf, or providing patient educational materials in large print or braille. Failure to provide these is a direct violation of federal law.
The legal definition of disability needed to be reinforced later, though, leading to the ADA Amendments Act of 2008 and 2009. Why was that necessary?
Well, the original act had been interpreted too narrowly by the courts, resulting in a lot of people with significant limitations being excluded from protection.
I see.
The 2008 Act broadened the definition significantly. It emphasized that an impairment that substantially limits a major life activity should qualify. And, crucially, it specified that the effective use of assistive devices or medical therapies, with the exception of corrective eyewear, does not negate the existence of the disability.
So if a patient is able to walk because they use a sophisticated prosthetic limb, they are still protected by the ADA.
Exactly.
The focus shifted from determining if someone qualified to simply making the accommodations.
That's it. The goal is to maximize participation and remove barriers, regardless of how an individual manages to function. This all underpins the patient's fundamental, legally mandated right to equal care.
Despite these powerful laws, we know that health disparities persist. Compliance is slow and unmet needs are common. So nurses, then, must be the internal advocates. And the source material provides a systematic assessment framework, a mandatory checklist to ensure quality healthcare.
This framework is so critical. Let's walk through the essential areas that should guide every patient encounter involving disability.
Start with communication.
The nurse must assess. Are necessary accommodations being provided immediately? Is the conversation directed at the patient? We have to resist that tendency to speak through a companion or a family member.
Right.
And are we consistently using people-first language? If the answer to any of these is no, we are already violating the principles of respect and effective care.
Next, accessibility of the healthcare facility. This is the physical reality check.
Does the clinic, the exam room, the restroom, the lab area meet physical accessibility standards? Is appropriate, adjustable equipment available? Adjustable exam tables are a must, especially for gynecologic or physical exams.
And is a certified interpreter available and used rather than relying on a family member?
Which compromises privacy, confidentiality, and accuracy. Yes.
Then the assessment itself, both general and specific.
The general assessment must confirm that the patient is receiving recommended preventive screening mammography, colonoscopy, cholesterol testing, just like everyone else. The specific assessment has to address disability-related needs. Do we need physical modifications or creative positioning for a thorough physical exam? Are we comfortable asking about sexuality and reproductive health, which are so often wrongly ignored in this population?
The checklist moves next into critical risk management areas, specifically abuse and depression.
We have to systematically assess the increased risk for abuse, physical, financial, emotional, or sexual. which may be perpetrated by family, companions, or even paid care providers.
And if abuse is suspected?
We must direct the patient to accessible shelters and resources. Furthermore, we have to screen for depression and offer treatment, pushing back against that societal assumption that depression is normal for someone with a disability. It's treatable, and the patient deserves treatment.
And we also must assess the patient's perspective on aging and the presence of secondary health conditions.
Right. The nurse must actively ask what concerns the patient has about aging with their specific disability. How will their condition impact their future function and support needs? And are we actively assessing for and preventing those secondary conditions like UTIs, pain, or pressure injuries?
Finally, the checklist requires considering modifications in nursing care during hospitalization.
If the patient is hospitalized, are we maximizing independence? Are there personal assistive devices and communication aids immediately available? If they're acutely ill and immobilized, are we intensely addressing the risks of immobility, recognizing that their baseline limitations mean they're at even higher risk for complications?
The entire focus must be on empowerment, avoiding dependence.
And that's the goal.
That systematic checklist provides the structure. Now let's ensure the interaction itself is successful. Segment 4 details the essential clinical communication strategies, because even the most accessible facility fails if the staff treats the patient poorly.
This section outlines how we translate that person-first philosophy into action. First, some general rules. Always treat adults as adults.
Seems simple.
It should be. Never patronize or make physical contact, like patting them on the shoulder, without permission. When offering help, ask how you can assist. And if the offer is declined, do not insist. Let the person set the pace.
And the primary rule here is addressing the patient directly.
Even if they have a companion or interpreter, absolutely. The communication is between you, the nurse, and the patient. Never speak through the companion unless the patient explicitly asks you to. You have to convey respect and agency.
For patients with mobility limitations, what are the critical etiquette points?
Never make assumptions about their ability or need for assistance. Do not push a wheelchair or grab their arm without explicit permission. Their mobility aid a cane, walker, wheelchair. It's an extension of their personal space.
Right.
Never move it without consent.
And the most important behavioral cue.
If you are having a conversation for more than a minute or two with a patient seated in a wheelchair, sit down so you are at eye level. Looking down at a person reinforces a power imbalance. It's demeaning.
Moving to vision loss.
When you enter the room, identify yourself immediately. If you need to alert them to your presence, lightly touching their arm is appropriate before you begin speaking.
Okay.
Speak directly, using a normal tone. When offering guidance, allow the person to take your arm. You guide them, rather than propelling them. And when giving directions, be precise. Use clock cues. The chair's at 3 o'clock.
And crucially, never distract or pet a service animal.
Without the owner's permission. Yes.
How do we navigate communication with hearing loss?
Start by asking their preferred method of communication. Hearing aids, lip reading, written notes, an interpreter. If you use an interpreter, maintain eye contact and speak directly to the patient, not the interpreter.
Right.
Speak clearly, but don't shout or exaggerate your words, as this distorts lip movements. Face them, keep your mouth visible, and if you don't understand, just politely ask them to repeat or write it down. Do not pretend to understand.
For those with speech disabilities or difficulties?
Patience is key. Allow them ample time. Do not interrupt or speak for them. Give them your full, undivided attention.
And if they use a communication device?
Ask for guidance on how to use it best. You can use short questions that require brief answers or nods to expedite essential information, but always avoid patronizing them with oversimplification.
Next, intellectual or cognitive disabilities.
Again, treat adults as adults. Adjust your communication by using concrete, simple, direct sentences. Avoid abstract language.
So the nurse will be back at 4:30, not in 15 minutes.
Exactly. Give exact instructions. And be aware that they might be eager to please, which can lead to inaccurate answers, so always verify responses by repeating the question in a different way or using an alternative explanation to confirm comprehension.
And finally, communication with individuals who have psychiatric mental health disabilities.
Speak directly using clear, simple language. Listen attentively and wait for them to finish their thoughts. Do not patronize, blame, or moralize about their condition.
Recognize it as a complex biomedical issue.
It requires treatment, not simply willpower. We have to actively question media stereotypes and just relax. Most people with psychiatric disabilities never exhibit violence, and they share the same fundamental needs and desires as any other patient.
These communication protocols are essential, but we have to acknowledge the broader context. Despite all these legal mandates and communication guides, significant barriers to healthcare persist.
They do, leading to continued disparities.
Let's outline those core challenges, starting with the most tangible: structural barriers.
These are the physical obstacles. Stairs, lack of ramps, doorways that are too narrow, inaccessible restrooms, non-adjustable exam tables.
The things you can see and touch.
Exactly. And while these are often the easiest to identify and legally eliminate, the slow pace of compliance means they remain significant hurdles.
Then there are the internalized, less visible barriers.
Attitudinal barriers. These are perhaps the most insidious.
The stereotypes.
The negative stereotypes held by providers, staff, and the public like believing that people with disabilities have a poor quality of life or that they're overly dependent. These deep-seated attitudes make obtaining equitable, respectful care incredibly difficult.
And the large, overarching systemic barriers.
These include lack of accessible transportation, difficulty finding a provider who is knowledgeable about their specific disability, financial strain. The list goes on. The sheer energy expenditure of just daily life can also act as a systemic barrier to seeking care.
The source material specifically highlights a concerning disparity in women's health care.
This is a major equity issue. Women with disabilities are significantly less likely to receive critical preventive screenings, specifically pelvic exams and pap tests, compared to women without disabilities.
Why is that?
The reasons include difficulty safely transferring onto standard exam tables, the lack of accessible equipment, and provider insensitivity or lack of knowledge regarding adaptive techniques. This failure in prevention can have devastating consequences for early cancer detection.
Okay, we now transition into the core concepts of chronic disease and multiple chronic conditions, or MCC, which really forms the bulk of medical surgical nursing practice. This is segment 5.
Right, and chronic disease, as we defined it, is irreversible, has a prolonged course, and is unlikely to resolve spontaneously. These non-communicable conditions just dominate healthcare today. Patients typically present with constellations of symptoms:
Pain, fatigue.
pain, fatigue, sleep disturbances, and significant psychological difficulty adjusting to the condition's trajectory.
And nurses today are not just dealing with one chronic condition, they are frequently managing multiple chronic conditions.
MCC is defined as the presence of more than one chronic disease, and the numbers are alarming. Approximately 117 million adults in the U.S. have at least one chronic condition.
And 3 in 4 older Americans have MCC.
3 and 4. This patient population is growing rapidly and presents profound challenges.
What makes MCC so incredibly complex for nursing care?
The complexity is exponential. MCC raises the risk for conflicting medical advice from multiple specialists, unnecessary and duplicative diagnostic tests,
Polypharmacy.
a high potential for adverse drug effects, yes, and an increased rate of preventable hospitalizations. The sheer administrative and medical burden on the family and patient becomes overwhelming.
And the financial reality of MCC is perhaps the most devastating system indicator.
It accounts for a massive 80% of all healthcare costs in the United States.
80%.
And for individual families, the out-of-pocket expenses just skyrocket with each additional condition, leading to staggering financial strain and often medical bankruptcy.
We also see health disparities strongly tied to chronic disease prevalence and outcomes.
There's a strong inverse relationship here. Poverty and lack of insurance significantly decrease the likelihood of receiving necessary preventive screening, which can delay diagnosis, and proper ongoing management.
And the chronic conditions themselves can make poverty worse.
Exactly. Due to lost work or high medical costs. We see these disparities clearly in mortality rates, like the persistent gap in breast cancer mortality between African Americans and Caucasians in some regions.
Let's quickly review the major causes driving this surging incidence of chronic conditions globally.
The causes are interlocking. First, we have decreased mortality from acute disease. We're saving people from infections, trauma, and acute heart events that used to be fatal decades ago.
So survival translates into long-term management.
Of chronic sequelae.
Yes.
Second is the prevalence of unhealthy lifestyle factors.
Smoking, stress, poor nutrition.
Sedentary behavior. They significantly increase the risk for hypertension, diabetes, and heart disease.
Third, technology and pharmacology have contributed to longer lifespans.
People are simply living long enough for multiple cumulative chronic conditions to develop and progress. And fourth, improved early detection and screening procedures mean we're diagnosing conditions earlier and more frequently.
And finally, the global factor that links so many of these conditions, the obesity epidemic.
This is a crisis. Approximately one-third of global population is affected by overweight or obesity. That's 2.1 billion people. This directly drives the increasing incidence of stroke, type 2 diabetes, hypertension, and heart disease. In 2015 alone, high BMI contributed to 4 million deaths globally.
Given these risk factors, the focus for nursing intervention has to pivot heavily toward prevention strategies. The CDC identifies several key modifiable risk factors we have to target.
Nurses must focus patient education on hypertension control, eliminating tobacco and NDS use, reducing obesity through diet and exercise, eliminating excessive alcohol use, and promoting diets rich in fruits and vegetables.
The WHO also laid out a cost-effective global strategy for prevention.
Right, these are high-impact policy-level interventions, things like reducing tobacco and alcohol affordability through taxes, mandating smoke-free environments, promoting dietary salt reduction, and replacing trans fats.
And promoting immunization.
Crucially, for diseases like hepatitis B and HPV, which are essential for preventing liver and cervical cancers.
This transitions us to segment 6, the experience of chronic illness, the non-physiologic human reality of living long-term with these conditions, and the resulting nursing implications.
We have to move beyond the pill and procedure approach and recognize the profound impact chronic illness has on a person's life every single day.
Let's discuss the deep psychological and social issues.
The chronic nature of the illness threatens the patient's core identity. They face role changes within the family and work, an altered body image, and this continuous need to adapt.
So when symptoms worsen, that shock and anger can come right back.
It can recur throughout the illness trajectory, yes.
And the non-linear, often unpredictable course of illness is a major stressor.
Chronic conditions involve constantly changing phases. Stable periods, unstable periods, acute periods requiring hospitalization, flare-ups, remissions.
So the primary psychological stressor is living with uncertainty.
Absolutely. Even in remission, the fear that symptoms will return profoundly limits a person's long-term planning and emotional stability.
This uncertainty and complexity directly undermine adherence to therapeutic regimens.
Therapeutic regimens are often incredibly complex, persistent, and disruptive. Non-adherence isn't just forgetfulness. It often happens when the side effects of the medication are more disruptive or troubling than the symptom of the illness itself.
Or due to cost or inconvenience.
Exactly. Nurses have to explore these barriers without judgment.
The impact on the family and caregivers cannot be overstated.
Family life is dramatically restructured. We see role reversals, loss of income, immense financial costs. Over 16.6% of U.S. adults are serving as family caregivers.
And that group experiences high rates of stress and fatigue.
Exceptionally high rates of stress, fatigue, depression, and missed work. When you assess a patient, you must always assess the well-being and capacity of the family caregiver.
The reality is that the home is the center of care. Hospitals are transient places for acute management.
Exactly. Day-to-day management medications, diet, symptom monitoring is primarily the responsibility of the patient and family at home. Hospitals and clinics are adjuncts. This underscores the absolute necessity of rigorous, clear discharge teaching.
And finally, the crushing financial and ethical burdens.
Management is exorbitant. Copays, deductibles, and loss of income frequently push families into bankruptcy. And while the ACA helped, the sheer cost remains a massive barrier. Ethically, it raises complex issues about resource allocation and defining the patient's desired quality of life.
So, given this intense reality, what is the resulting nursing role in management for chronic illness?
Our role begins with prevention. But once a chronic disease is established, the focus shifts to expert symptom management, proactive complication avoidance like teaching proper foot care and diabetes to prevent ulceration, and maintaining or improving the patient's quality of life.
So we have to provide the education and resources to help the patient integrate the illness into their overall life plan.
That's the goal. Integration.
That concept of integration requires seamless support, which brings us to segment 7. Nursing care across settings and special populations.
Care during hospitalization has to be highly individualized. We must maximize independence, adjusting bed height, ensuring personal assistive devices are available, and establishing communication methods immediately.
And for patients with service animals.
Appropriate arrangements must be made to accommodate the animal's needs and safety protocols.
And for communication needs during an acute stay.
We have to establish effective methods instantly. For communication deficits from a stroke or TBI, early consultation with a speech-language therapist is essential to identify the most reliable alternative methods. Communication boards, gestures, eye
What
movements,
the cognitive disabilities?
consistency, promoting a safe environment, and consulting with family caregivers about their established daily routines are vital.
Let's talk about health promotion and screening. The presence of a disability is not a reason to defer standard screening.
Often it's a reason to intensify it. That is a critical professional standard. General health screening applies to all people with disabilities. Mammography, testicular exams, prostate exams. Furthermore, the disability itself may increase the need for specific screening.
For instance,
For example, patients with limited weight-bearing activity or those taking certain medications like long-term steroids may need earlier and more frequent bone density testing.
nurses have to act as navigators here, overcoming those structural barriers we discussed earlier.
We must refer patients only to accessible sites for screening, exams, and exercise programs. We also need to be proactive in areas often overlooked due to societal discomfort, like providing comprehensive education on safer sex practices.
Finally, let's look at transitional and home care. Discharge planning is the final mile for chronic illness management.
The nurse has to assess how the disability affects the patient's practical ability to adhere to treatment. Can they physically manage the medication schedule? Can they arrange transportation to accessible follow-up clinics?
The source material details a valuable home care checklist for discharge teaching.
We must ensure the patient or caregiver can articulate the illness's impact on ADLs, knows medication side effects, can demonstrate the safe use of adaptive equipment, and can identify community resources like support groups.
The role of the transitional care nurse seems ideal for patients with MCC.
Absolutely. These specialized nurses manage complex patient loads, coordinating care between multiple providers, conducting home visits, and providing telephone support to catch early signs of deterioration,
And thereby preventing rehospitalizations.
which are costly and dangerous, yes.
We should also recognize the growing importance of telehealth in this management model.
Telehealth is a vital tool using electronic technologies for long-distance clinical care and support. It's particularly effective for monitoring chronic conditions and providing access to specialists for patients in rural areas where travel is a major barrier.
Let's conclude this segment by touching briefly on two key special populations, veterans and older adults.
Veterans have a significantly high rate of service-connected disability, particularly those who served in recent conflicts. Nurses must take symptoms of chronic multi-symptom illness, CMI, or Gulf War illness, GWI, seriously and validate the patient's experience.
And the first step is simply to remember to always ask every adult patient.
Have you ever served in the military?
And for gerontologic considerations.
The majority of Americans over 85 experience functional limitations. Crucially, people who are aging with pre-existing disabilities often experience age-related changes earlier.
For example,
Chronic crutch users may develop shoulder and elbow overuse injuries sooner, or post-polio patients may see increasing respiratory symptoms decades after the initial illness. Nurses have to address the patient's concerns about future physical and financial supports.
and assist aging parents of adult children with developmental disabilities in planning for their adult child's future care.
That is a critical and often forgotten part of the job.
This deep dive has provided an extensive practical framework for approaching disability and chronic illness with professionalism and compassion. Let's summarize the two essential nursing mandates we've covered.
First, mastery of the federal mandates, the Rehabilitation Act and the ADA, and the systematic assessment required to eliminate structural and systemic barriers.
We have to ensure our facilities and procedures uphold the patient's legal right to equal care.
Absolutely.
And second,
A holistic approach to chronic illness that supports the patient's self-management, acknowledges the immense psychological and social burden on the family, and prioritizes the patient's desired quality of life over the mere pursuit of a cure.
we have to focus on integration, not eradication.
Precisely.
Here's where it gets really interesting and where we leave you with a final thought for reflection. The sources we reviewed pointedly noted that despite decades of legislation and educational efforts, progress has been slow in ensuring that healthcare professionals receive adequate training about providing high-quality, barrier-free care for people with disabilities.
That gap between the legal mandate and the clinical reality is profound because it's not just about fixing concrete, it's about fixing cultural assumptions and attitudes.
So consider this. If the system itself remains structurally and culturally reluctant to fully embrace the principles of people first, barrier free care, how can you, as an individual nurse, transform that institutional reluctance and attitudinal bias on a shift by shift basis? How do you ensure that in every single circumstance, the healthcare system truly sees and empowers the person first? That determination is the true essence of nursing advocacy.